From Rocky Mountain PBS News, this is Colorado's State of Mind. Tonight, infant mortality among Black families in Colorado is high, and the reasons you might guess don't seem to apply here.
Even if you take the wealthiest Black woman, her rate of preterm birth is still higher than the poorest white woman.
We'll tell you about research in Denver that measures the stress levels of Black women, stress that could prove fatal to an unborn baby.
They're diseases that African Americans have because their race. I think it's the same issue. It's the stresses of racism.
Good evening, I'm Katie Wilcox, filling in for Cynthia Hessen. Racial disparities in health have been well established in numerous studies, showing a higher prevalence of chronic conditions and higher mortality rates among Black and Latino Americans compared to white residents. Poverty, education, geography, lack of access to adequate health care provide part of the explanation. But for Black Americans, these socioeconomic factors do not explain the disparities in infant mortality. Instead, medical researchers in Colorado are looking at another culprit.
We know that Black women have higher rates of poverty, experience much more discrimination.
Dr. Susan Wang has spent years studying disparities in infant mortality. She says her research has shown that stressful life experiences, like being fired, having your partner go to jail, struggling to provide meals for yourself or your children, all of those kinds of things can make people less healthy. And this is especially apparent with minorities.
What we typically consider to be non-medical reasons do cause biologic disruptions.
A biologic disruption, that could include a miscarriage or maybe a stillbirth, even an early delivery, endangering a fetus or infant's life. And while public health data show a link between poverty and infant loss for most races, it's not the same for Black families. Black families at all income levels are more likely to lose their babies in the first year. And the same is true for education. Neither a college education nor a stable middle-class job decrease the gap between Blacks and all other races.
Unlike other differences we see in health, other health disparities, mortality, infant mortality, is not explained by education level or income level.
You see that economics doesn't explain it all.
Here's what the state public health data does explain. A middle-income Black family earning $50,000 to $75,000 a year is just as likely to lose their baby as a Black family making less than $15,000 a year. And when compared to a middle-income white family, the Black family earning the same income is 4 times more likely to lose their baby. To look at this another way, in Colorado, a middle-class Black family is more than twice as likely to lose their baby than a white family living below the poverty line.
That is absolutely consistent with national data as well, that even if you take the wealthiest Black woman, her rate of preterm birth is still higher than the poorest white woman.
The numbers are equally true for education levels.
A Black woman who's been to college could have the same likelihood of having a bad outcome in terms of her pregnancy as, say, a white woman who hasn't finished high school. So the benefits that accrue to education and increased income aren't felt equally by all groups in our country, and we have to understand some of why that is.
So why is it that women who are otherwise achieving in the culture, well-paying job, climbing the career ladder, otherwise seeming to do well in this society, would have such high infant mortality rates?
At Denver Health, Dr. Camille Hoffman thinks she can find the answer in clippings of hair from patients like Adora Loftus.
Our assumption is that African American moms have higher levels of stress, and that may be part of the relationship with preterm birth in that population.
The stress hormone Dr. Hoffman and her team are measuring is called cortisol. Cortisol is released by your adrenal glands when you're confronted by stressful events. It's your fight or flight hormone. Studies have proven that too much cortisol can be toxic. At high levels, it can alter your blood vessels, increasing your risk for heart attack or stroke. Cortisol is also a marker for anxiety, heart disease, and diabetes. Long-term exposure to heightened levels of cortisol can reduce life expectancy. In pregnant women, the hormone is linked to fetal loss and premature birth.
Using the hair cortisol versus the other measures that I mentioned out of blood or saliva also gives us kind of a chronic or overall picture of a stress status. So when we measure cortisol or other stress hormones in blood and saliva, that can be influenced by a bad morning, an event that happened 5 minutes before you saw that mom in clinic. With hair, you won't capture those same kind of spikes and highs and lows, so you just kind of get an overall baseline cortisol status or stress status. But that gives you more of a reflection of someone's overall life accumulation of stress.
Here's how that works. Every month, our hair grows about 1 centimeter longer, giving researchers like Dr. Hoffman an opportunity to, in effect, look back in time. So as she measures a strand of hair, she can test her patient's cortisol levels prior to that patient's pregnancy. Here's what Dr. Hoffman is finding.
African American moms have higher stress hormone levels in both hair and in blood and saliva than white non-Hispanic moms and Hispanic moms.
But why? Where does that stress come from? And what makes it unique for Black families as opposed to that of any other race? Even those Black families who are not exposed to the stresses of poverty. When Sheila Young was pregnant with her daughter, Streisand, she and her family lived in a nice home. They had stable jobs. Both she and her husband had their bachelor's degrees.
Back then I was probably upper middle class. Yeah, my kids went to private school. They did all the things that, well-to-do kids are supposed to do. They did ballet, they did music lessons, and they went to camp, and they had a very nice childhood, I think.
But even raising her children in a well-educated, well-off, two-parent home didn't stop Sheila from feeling the stress associated with her race.
Well, they're diseases that African Americans have because their race. Like I have high blood pressure and I have diabetes. And, you wonder why is this only prevalent in the African American community? I think it's the same issue. It's the stresses of racism.
And racism comes in many different ways. If you're Black, studies from around the country show that your name may turn employers away from your resume, or lenders might refuse to finance your home.
It's the stresses of, am I going to be able to provide for my family? All those things. Am I going to be safe? If I live in this certain community, I might be able to afford it, but are my kids going to be safe when they go to school? Or are we going to be safe in our house? Is somebody going to try to break in on us? Stuff like that.
Are my children going to the right schools? Are they safe? Am I secure in my job? All of those very stressful things build up day after day. And now, in Dr. Hoffman's study, we're better able to measure the buildup of stress in hair. And it's consistently higher in Black mothers.
Studies have demonstrated that maternal report of racism is associated with higher reported rates of stress, inflammation, infection, and preterm birth. And so there's enough literature out there that demonstrates that. And given that prematurity is the leading cause of infant mortality, it just naturally leads into a higher risk of infant death if mothers are perceiving higher rates of racism in their life.
Joining me now to discuss racial disparities in health are two Colorado public health experts. Nita Mosby-Henry is with Children's Hospital Colorado, where she's the Chief of Human Resources and Inclusions Officer. In 2007, she founded the Kaleidoscope Project in Denver, a response to health disparities in communities of color. Also with us is Dana Bowen-Matthew, a professor at both the University of Colorado Law School and the Colorado School of Public Health. Dana formed the Colorado Health Equity Project to help low-income patients with legal needs that may be affecting their health. Thank you both so much for joining me.
Thank you. Pleasure.
So what I learned sort of in the product making this documentary is that income and education didn't have the same sort of impacts on infant mortality as we maybe expected from the beginning. And really, they don't seem to have much impact for African Americans at all. I'm wondering, have you seen this in any other aspects of healthcare?
Absolutely, Katie. And one of the things that we see pervasively is that race really does matter. Ethnicity really does matter where the quality of healthcare is concerned. So even when we equalize income and education, we still see vast disparities. One of the best examples is cancer. And it's not just about income, it's not just about socioeconomic status. It's about discrimination that occurs in health care, albeit unintentional, but discrimination nonetheless.
Nita, when you and I talked, we mentioned, you talked about there's not anyone necessarily being ill-willed. This is just something that our country and institutions have dealt with for so long that it's ingrained. I think in your book you mentioned, you call this same sort of phenomenon implicit bias. Nita, could you explain a little bit what you mean about by institutional racism or implicit bias?
Yeah, I think oftentimes in healthcare we separate healthcare from some of the other social factors that exist in our country and their relevance to people's wellness, generally speaking. And institutionalized racism is one of those core parts of social factors that we oftentimes ignore. And when you talked about earlier, when you both talked about sort of this notion that income and education may not play in this disparity, well, institutionalized racism doesn't really care about your income or your education. And so we have to start looking at those social factors as integrating factors in the way in which we're even talking about this issue.
When I was reading your book, I noticed there was a really fascinating survey of about 400,000 people looking at implicit bias. Could you describe that a little bit so we can understand?
Yes, let me start by telling you what implicit bias is.
Okay,
it's a function of what Nita's describing, institutional racism. Implicit bias is a negative attitude towards people because of their race that occurs automatically, that is unintentionally. Like Nita says, you don't have to have a doctor with an ill will or with a bigoted heart. But that doctor, because he or she lives in a place where institutional racism affects what we hear on television, it affects the political discourse, the sounds we hear in music, the movies we see, the experiences we have, all of that feeds our unconscious and unintentional perceptions. And so when that implicit bias triggers, what happens in a medical encounter is that a physician may not intentionally mean to do so, but he or she will make less eye contact, will speak less directly, will have a shorter interview with a patient of color than a patient would have had if they were white. And most precisely, and perhaps most detrimentally, will make different treatment decisions because of that implicit bias. So implicit bias, I think, directly contributes to healthcare disparities. Someone has actually estimated that 84,000 people of color die annually unnecessarily because of health disparities.
Nita, you work in a hospital with doctors. You're the chief inclusion officer. Tell us, well, what exactly is that? But also, how can doctors kind of deal with their implicit biases? And is that something you guys are working on?
Yeah, we really are. I'll start with the title. I think it's a fascinating title to hold. I think I'm one of few people in healthcare that actually hold the title of chief inclusion officer. That's in contrast to what most people hold, which would be chief diversity officer. But Children's Hospital Colorado made a conscious decision to take diversity to the next level, that we are more concerned about the same things that Dana talked about. What do we need to institutionalize in our own organization to end health disparities? And that inclusion piece is what it's all about. We're talking about things like unconscious bias, implicit bias. We're talking about those things in the workplace. Our workforce is talking about it. Our physicians are talking about it. Actually, just this morning, Children's Hospital Colorado signed a pledge, a national pledge to end health disparities through the American Hospital Association. We're serious about this work. So the title really, I think, is reflective of that. I also believe one of the things that we're doing at Children's, and I would just encourage everyone else to be thinking about around this topic, is when we talk about health disparities, I don't think you can talk about the disparity without, in the forefront of our thinking, talking about what equity really means. And so it's sort of a problem-based way to take a look at healthcare when you just talk about the disparity. So I think as we move forward in this work, as we're talking about infant mortality and we're talking about all the other disparities that hit the African American community, if at the same time we're not contemplating what equity looks like and what the systems of equity look like, I think we'll be talking about disparities 20 years from now.
Absolutely. You know, I remember when I was reading and kind of thinking about this, you guys are really talking about this sort of subconscious thing that is happening, something that nobody even meant to do. How can you train someone to not have that or not act on their implicit bias?
Well, the first step is what it sounds like Nita's groundbreaking work at Children's Hospital is doing. It sounds like Children's Hospital is changing the social norm around implicit bias. If we ignore that it occurs, like Nita said, we'll be talking about this for another 25 years. But the first step is to acknowledge that it occurs. The first step is to acknowledge that by some estimates, over 70% of Americans have an unconscious bias that is against blacks and against Latinos as compared to whites. So what we do first is acknowledge it, change the social norm around whether this is or is not acceptable. Then the type of acknowledgement that would lead to stereotype negation, that would lead to diversifying the workforce, that would lead to regular training similar to what we have done, for example, with HIPAA in hospitals that respond to laws by changing pervasively what the conversation and behavior is about. These are the kinds of changes that will help. I want to pick up on something also that Nita said, and that was we can't limit our discussion of implicit bias or disparities to just what happens in the hospital context. When you change a patient's educational environment, a patient's food security, a patient's housing, all of those things will also contribute to changes in their health outcomes and reduce disparities. But it's the physician, it's the provider who becomes an advocate. If their implicit biases are reduced, then they become like, well, think about Flint. Think about Dr. Mona Hanna-Attish. She is a physician not just to the patients that she treated in Flint, but to the entire community. And when you reduce implicit bias in the healthcare context, you'll have a lot more Dr. Mona Attishes.
That's right.
You work not only with how doctors relate with patients, but also, you know, you oversee all these different doctors and people working in the health in Children's Hospital Colorado. And I think another place where people want to see improvements is in the workplace. Mm-hmm. Do you guys focus on that?
Yeah, we do. It's almost simultaneous work. I actually think you can't do one without the other, and if you don't create the infrastructure within the organization to support all of the things that Dana's talking about and that we're talking about here, then there's really no way to carry that out in the greater system. So we have a consciousness within the organization about the importance of that in our workforce, and that goes from basic workforce diversity programs to some that I think are pretty provocative. We're looking at partnerships, job pipeline programs with refugees. And what does that actually mean downstream in the way in which we serve our refugee populations if our staff themselves are refugees? And so those kind of things I think are provocative and necessary and have everything to do with what we're talking about today.
I wonder, I was listening to this often, and in your book, of course, you mention even those people who have all the best intentions and fully recognize what racism is and want to do something very proactively, might still have an implicit bias. What could you tell a viewer maybe watching right now, what's something you could do today or tomorrow that might help?
So the first thing I would encourage a viewer to do is go onto the web and take the Project Implicit Bias Test. It will likely shock you to find out that as progressive, as egalitarian, as equal-minded as you are, because you have an environment surrounding you that tells you information that is negative about people of color, you likely have implicit biases also. Let me hasten to add that does not make you a racist. That does not make you a bigot. That does not make you a bad person. But by simply finding out that you have implicit biases, the data tells us that doctors will change their treatment patterns just because they know that they are susceptible to this type of bias. If you're a viewer who is a patient, I would advise you to become an active participant in shared decision making, in the active conversation about your health with your provider. I would encourage you to make eye contact with your provider, to ask questions of your provider, and to make sure that the combination of your interests in your own health and your own health outcomes are shared evenly between you and your provider. That will change your provider's unconscious biases about you as a member of a group to knowing you as an individual.
And how can that change specifically what happens? I mean, we obviously have seen that in some cases infant mortality, right? That leads to an infant dying, maybe at premature birth. What are some other ways that people experience this? You mentioned cancer.
Well, cancer is an example because the disparity rates in cancer have been well documented for years. African Americans and people of color generally have a 33% less likely chance of survival of all major forms of cancer. However, the travesty about this is that it is not because of their genetics, it's not because of their clinical features, it's because they are diagnosed later. People of color are treated less intensively. They are educated less thoroughly. For example, they are less likely to find themselves on a list for transplant or even be told that transplant is available to them. This is how implicit bias permeates the clinical encounter and how it changes the chances of survival. Cancer is an excellent example because when those treatment disparities are equalized, we find that the 5-year survival rate for blacks and whites are equal. That tells us that it is the difference in the quality of treatment that people are receiving, as opposed to anything that is genetic or biological. And that is untenable. That must be changed.
As far as making some of those changes, you mentioned earlier that Children's Hospital Colorado sort of made this commitment. What are some of the details of that commitment?
So the commitment starts at a very grassroots level. It starts with what you do with your staff. And the commitment is around the governance of the hospital. What does your board composition look like? What does your executive composition look like? What does your staff composition look like? What training are you providing across the system that will allow us to create a system of health equity? And from there are steps within the pledge that talk about creating evaluation measures around whether or not we're tracking race and ethnicity of our patients. Are we measuring health outcomes? Are we able to take disparity to equity? And is there a way to really evaluate that and measure it? So we've pledged to work in all of those different swim lanes and are very excited about it. I think that's groundbreaking work. I don't think that happens naturally in healthcare. I think it's happenstance oftentimes when we talk about health disparities that we actually have a plan by which we move to health equity. So I'm excited to be a part of that.
I'm going to echo what Nita said. It doesn't happen by chance. These individual disparities, these individual instances of unconscious bias mount up to create the kinds of numbers that it was Dr. Satcher who calculated the 84,000 people dying from disparities. And when an institution takes the steps that Nita's describing, they are a beginning of the answer. But this is an institutional, a systemic problem. And that's why in Just Medicine I advocate for a change in the law to recognize that unconscious bias is actionable, is illegal, so that the social norms in this country will no longer tolerate unconscious bias. Now let me quickly point out that if a hospital like Children's Hospital, with the kinds of changes that Nita has described, was ever named as a defendant, then they would quickly have a defense to such a suit. And they would quickly be able to say that they acted reasonably under the statute as I propose it to change. But indeed, I do encourage legislators, policymakers, lawmakers everywhere to change the anti-discrimination law to make surely clear that unconscious bias is also illegal in this country.
Agreed. Thank you both so much for your insights tonight and for joining us this evening. This has been Nita Mosby-Henry and Dana Bowen-Matthew. Next week at this time, you can see our full documentary on infant mortality in Colorado, when we'll introduce you to some of the people who have experienced this precious loss.
People think, well, we live in the 21st century. We have all of these hospitals and all this equipment. It's mind-boggling. I'm not trying to make this up. I'm not looking for a sob story. This is true. It knows no boundaries because this is a problem nationwide. It's not just a problem here in Colorado.
Rate of infant mortality, that is the number of babies who die before their first birthday, in the United States, that means that's 23,000 babies that die before their first birthday. What I want for our country is to not tolerate the fact that our children have different rates of survival to their first birthday based on their race and ethnicity. I would like one number. One number for our whole country would be fantastic.
Really, everybody deserves a first birthday.
As Arvian Harper and her 1-year-old daughter Ellis are playing drums on their living room floor, her husband Marcus and 3-year-old son Porter are practicing the alphabet.
His patience with them, I don't know. Like I feel like you're definitely an amazing husband and a good friend too. But
did you get all that?
You're just a really great father.
They're high school sweethearts, married for 8 years, but together for 15. And the joy their family shares helps them cope with the grief of losing their first daughter.
Now that I know what it is to have a relationship with your kids and from a dad's perspective to be longing for that, I appreciate what I'm missing more, even more now. That's something I never even told you before today.
Please join us for Precious Loss, our special documentary presentation next week on Colorado's State of Mind. From Rocky Mountain PBS News, I'm Katie Wilcox. Good night.